Okay, so welcome everyone to PCEP for May 2024. For those of you who are here in person in North Country EMS, thank you for coming, and welcome to everyone who's online. Feel free to jump in with questions, both live and online. You can raise your hand or put questions in the chat. So today we're going to review the ALS management of cardiac arrest, and then we'll give an introduction to where we're going with mechanical ventilation. We're going to talk through the whole chain of survival and look at opportunities to improve, and I'll share the data that we have recently about where things are going with our cardiac arrest data. As always, our purpose is to provide consistent, high-quality emergency care to our patients where and when they need it most. And so everything that we talk about today should relate back to that. The outline for today, I have a few updates. We'll talk about what the medical program director's office is working on, things you can expect over the summer. We'll review the cardiac arrest data. We'll review cardiac arrest management. We'll take a brief break because I know this is a very full day. And then we'll talk about arrhythmias with a pulse, and then we'll talk about mechanical ventilation. So in terms of updates from our office, in terms of high quality clinical care, one of the things I wanted to give kudos to this system is that we've made consistent improvement in transporting patients without lights and sirens. That's a reflection of our philosophy that what our patients need in the vast majority of cases is just solid EMS care. And that this idea that in every case we scoop and run and drive fast is kind of a relic from an older time when we didn't have as much that we could offer patients as an EMS service. Now, certainly there are a small number of cases where the patients need something at the hospital that we can't offer an EMS, and we still allow for that operational decision. In terms of where we can make the system safer, we're looking at opportunities. I'm going through a review of call determinants, and we're looking at opportunities. One are the places where we can reduce lights and sirens response. And then also are the places where we can increase BLS response to 911 calls. And then also looking at some additional call determinants that can be handled by the nurse navigation line from dispatch. So those calls may never go into the 911 system at all. So those are kind of the big things that we're working on. In addition to that, we're working on the best way for EMS to treat opioid use disorder. We have more information coming about that. In terms of ongoing education, we're here now. We've released the schedule for a hybrid PCEP throughout the rest of the year, and so we'll be at different locations throughout the rest of the year. But obviously, we'll always offer both the live online option and the recorded option. In June, we'll be reviewing cardiac arrest, but there'll also be a chance both for transporting and non-transporting services to gain some more familiarity with ventilators and with how they integrate with our system. In terms of crew health and safety, big focus is in that safe reduction of lights and sirens use, both in terms of response and then in terms of the transport phase. In terms of effective teamwork, one of the things that I wanted to let you know is I've been meeting with the nurse midwives. It has been really hard for a lot of pregnant moms to get access to OB care. And so we expect to see an increase in home births over the summer, both at home and at the birthing center. So there are a lot of women that are due, that are expected to deliver in the summer. So use that as an opportunity to think through those calls, to visualize, and then we're going to look for any joint training opportunities we have. Something that we expect to see over the summer based on our conversations with our partners. And this is the data on our lights and sirens use as a system. So this is by week starting from July of 2023. And the straight line is the median, which has been 85%. But there's been just a steady a steady creep upward in the number of patients that are being transported without lights and sirens. That's safer for the patient, safer for you, and safer for the community. The biggest opportunity we have, I think, to shift this a little bit higher are yellow acuity patients. And so I want to be clear that there's nothing in protocol that requires you to turn on lights and sirens for a patient that's yellow acuity. Our point of view is that the decision to use lights and sirens is an operational decision. And so, are there situations where there's massive traffic and the only way to get through it is with lights and sirens? Yes, we want to give you that. We want to give you that tool, but we also want you to trust your judgment that if you think the patient is yellow acuity, you can get the patient there safely without lights and sirens. As a reminder, it saves, on average throughout Clark County, saves 97 seconds to turn on the lights and sirens. And so there are many other opportunities in the course of the call, shoot time, scene time, to make up that time. And so again, that's a priority on patient safety and on your safety. Any questions on the updates before we move on to cardiac arrest? Mark, anything online?
Nope.
So we'll go through the cardiac arrest data. We just got CARES data from 2023. And so I pulled together all the data since we started participating in CARES in 2014. So we can share that. So this is over time going by year from 2014 to 2023. This is all non-traumatic cardiac arrests. And so this is the survival percentage. First, the overall survival to hospital discharge is the bottom, the light blue line. And then the patients with sustained return to spontaneous circulation is that top line. And so we saw a decline in sustained return to spontaneous circulation in 2020 with the pandemic. And we haven't quite gotten back up to those pre-pandemic levels. We are still seeing a little bit less bystander CPR. And so we're thinking ways that we can address that. But we are finding that people are just a little bit more hesitant, even with hands-only CPR, to engage in CPR. But then overall survival to hospital discharge has been fairly consistent over time. When we look at the Utstein criteria, so these are patients with a shockable rhythm, and look at their survival over time. And these two numbers are Utstein survival is the dark blue line. That's all shockable rhythms. And then bystander survival are the cases that had bystander CPR. For us, those track pretty closely. So what we did notice, and this was something of a surprise in the 2023 data, because our return to spontaneous circulation for these patients has been the same year over year, but we're seeing more of these patients die in the hospital. And so I'm taking a deeper dive into the data to try to figure out why that's happening. I'd say anecdotally from looking at it, one, I think overall the percentage of shockable rhythms has gone down. We're in general, as a medical community, getting better preventing them, both by putting in AICDs, by putting patients that have heart failure on beta blockers, which decreases their likelihood of going into a ventricular arrhythmia. The other thing I noticed going through the data from particularly from 2023 is that a lot of, whereas in previous years there were typically some otherwise healthy patients who had a VFib arrest, most of the patients that we saw with VFib arrest in 2023 had some underlying comorbidities. That said, we got this data within the last week. And so we're looking at it and we're trying to figure out how we can improve survival in these cases. These are our most salvageable cases. This is our biggest opportunity to make an impact. And again, the percentage of those patients that are getting return to spontaneous circulation in the field is holding steady. But over the last year, we saw more of them die in the hospital. Mark, is there anything you'd add to that?
No, I would just emphasize the two things there. The one is citizen CPR and pad defibrillations have decreased. And that's probably pandemic related. And then Yeah, the comorbidities that we're seeing patients have. We don't have young, healthy people that cardiac arrest anymore that inflate our numbers. That's kind of what we've seen.
But that's it. We're taking a hard look and looking, is there anything that we can do as an EMS system to improve the care in that portion of the patient? And then also as a medical program director, I'm looking, what else can we do to improve bystander CPR rates in the community, public access to fibrillation? Any questions about the cardiac arrest data before we go on to management of cardiac arrest? So this will be reviewed, but I find it impossible to talk about the management of cardiac arrest without reviewing the BLS management, because like anything we do in EMS, without good BLS, none of the things that we do as ALS providers matter. So the principles of high performance CPR, EMTs own CPR, that at all times we minimize interruptions to CPR, ensure the proper depth of compression, ensure proper recoil, ensure the proper rate, rotate compressors every 2 minutes with manual CPR, to hover the hands over the chest during the shock, but then so you're able to get right back on the chest as soon as the shock is delivered, to place the IHL with ongoing CPR, to place the IV or IO with ongoing CPR, and to have the coordinated approach that we've developed over time. Why do we care about the recoil? Because during the compression phase, we increase the thoracic pressure, we eject blood from the heart and the lungs, we get that forward flow going. During the recoil phase, we allow the intrathoracic pressure to decrease. We see we allow the refill of the heart and the lungs. We get that vacuum that allows us to put more forward flow with the next compression. The perishock pause is critical to successful resuscitation. And so if you, with increasing pause length, you have decreasing survival, decreasing success of the next shock. So our goal is always to keep to less than 10 minutes in terms of interruptions in CPR. One of the things that we're trying to do as a system is better to be able to take the PCO files that the monitor generates and better analyze this to look for opportunities to improve. Now, moving on to ALS management, and we'll talk about specific things, but I also want to talk about the general approach. So for the paramedic in charge and everyone participating in the resuscitation, I think the underlying philosophy is like, how do we deliver oxygen to the heart and to the brain? Obviously, that's the key thing in CPR. And as you are, as you're standing over the patient, trying to figure out what do we do next, what do you do? This is, at least when I'm running a resuscitation, this is what's ultimately in my mind. How do I better deliver oxygen to the heart and to the lungs? And depending on the clinical situation, you're going to have a slightly different vision of what that looks like. And so what I would encourage you to do if you're leading on a call is to share what your mental model is. So you're looking at the individual skills that are being performed, looking to see how the resuscitation is coming together, having this awareness of how the overall situation is progressing, but then sharing your mental model. So that can be like, okay, this is a patient with defib arrest. Our priority now is to get defibrillation, get access, get amiodarone, and then as you update that, okay, we've now gone through 3 shocks. We're not getting any response. This is a patient that we may need to transport because they've got refractory defib. Let's get ready to do vector change, thinking of those next steps, and then sharing your mental model, because that allows the whole team to get on the same page. So to review the basic flow in working on cardiac arrest is to check the rhythm, to shock if shockable, to give the continuous high quality CPR, to support with drug therapy. There's no surprises, nothing new here, but this is kind of the underpinning for that mental model. How do we get oxygen to the heart and the lungs? So initial management, as you know, is to establish the unresponsiveness, to perform the continuous CPR, and then apply pads, get ready to defibrillate if it's a shockable rhythm. After those 2 minutes of continuous CPR, it's not a shockable rhythm, then our goal is to get epinephrine on quickly. The reason we do that is that we know that the sooner we get epinephrine on in non-shockable rhythms, the better chance we have of a good neurologic outcome. In the shockable rhythm, the goal is amiodarone first, based on research that was done, including in this system, that with the vast majority, VFib, amiodarone first is our best chance of resuscitating the patient. We begin with suprachoroidal airway and then establish access. If you can get an antecubital arm vein, but don't hesitate to go to a humeral IO. Don't use that for pediatrics, but for adult patients, humeral IO, distal femur, proximal tibia are also options. For someone who is in cardiac arrest, naloxone is not part of our routine management. Remember that the advantage of naloxone is that it allows you to stop bagging for a patient that stops breathing. In a patient in cardiac arrest, they've already stopped breathing. The naloxone isn't going to affect their cardiac output. If you do get return of spontaneous circulation, you may need to sedate, intubate this patient. You don't want to give them fentanyl, so it's not a part of our routine management. And for pediatric patients, use an age weight-based system. And then if the patient is not responding, consider death in the field. I do want to let you know, we are aware of a small number of cases where the patient met criteria to pronounce death in the field and base recommended transport. That worries us, and that's antithetical to how we think about crew safety and maximizing care for the patient. We are working intensively with that group and with reviewing our protocols to figure out the best way to handle that. A reminder of the pit crew model, and it's the idea is that this, by automating all of these steps, we give the paramedic in charge the mental space to think about how we deliver oxygen to the heart and the lungs. In terms of airway management, one thing I have seen in reviews, so we start with a supraglottic airway, but unless you are really getting good, good gas exchange, as evidenced by good end-tidal CO2 and good pulse oximetry, we have a low threshold to intubate. If the supraglottic airway really is working, it's really giving you good gas exchange, then do it. But if you can't say this is really working well, then don't hesitate to move forward with intubation, particularly with the video laryngoscopes. We have additional tools to help us to do that. But don't hesitate to intubate, but with ongoing CPR. So a couple of words about mechanical CPR. It is a tool. It has never been proven to be superior to manual CPR. So if for some reason it is not practical or it is not working for the patient, don't hesitate to just go with manual CPR. Contraindications, obviously size, too small and too large, traumatic arrest, pregnancy, or no that. But let me hear from you. When you've seen mechanical CPR not work, what are the reasons you most commonly see it not work? Too small.
Or too big.
Yeah, I mean those are the big things. So don't, and I agree. It allows, if for that patient with refractory VFib that you're moving, it allows CPR and movement during movement much better than manual CPR. But it's never been shown to have a survival benefit over manual CPR. So don't hesitate to just move to manual CPR if it's not working, or stay with manual CPR. So with that, we'll go into specific arrhythmias and some of the thought processes behind them. And we'll go from the most salvageable patients to the least salvageable patients. So we'll start with VFib and pulseless VTAC. So I think this is a heart that's irritable. It is either an electrolyte abnormality or it is starved for oxygen. There's something going on, but the heart is showing you that this is a salvageable heart. So defibrillation, as soon as we practically can, is the key to treatment. Continuing the CPR, giving the amiodarone, and then supplementing with epinephrine. As a reminder, then if you've done 3 shocks that are unsuccessful, change the vector. That is based on a paper that compared what are the best ways to treat refractory VF. I know south of the river they use double sequential defibrillation. There was no significant difference between vector change and double sequential defibrillation in terms of getting return of spontaneous circulation. There's a tiny signal about other things, but we find it largely impractical. Now, will we look at this again as part of our review of VFP? Sure, we'll look at it again. But for right now, vector change is both most practical and is proven to be as effective in getting a return of spontaneous circulation for patients in refractory VFib. And then if a second dose of amiodarone is contraindicated, for example, a patient in torsades, then you would lead with lidocaine. And the reason for that is that amiodarone of all the antiarrhythmics is the messiest. It has the effect of all 4 categories of antiarrhythmics. Patients in torsades often went into torsades because they had QT prolongation. Amiodarone prolongs the QT. So in that limited case of torsades, that's where lidocaine is our preferred antiarrhythmic. Obviously, magnesium is the first-line drug treatment for torsades. And then continue until you get to return to spontaneous circulation or get to the death in the field criteria. One of the things that's come out of most common research, most recent research, much less the absolute value of the end tidal CO2 that gives you information about what's going on, but whether it's rising. And if you're seeing rising end tidal CO2, then that's obviously a quick rise often correlates with the return of spontaneous circulation. Rising end tidal CO2 gives you some signal that this might be a salvageable patient. If it's staying flat, certainly if it's falling, then those are signs that this patient might not be salvageable. For pediatric patients, follow the adult algorithm, but keep in your head with that underlying model. We're trying to deliver oxygen to the heart and the lungs. Almost all of these are respiratory arrests. And so these are the cases where you really want to prioritize the oxygenation to do everything you can to deliver that oxygen to the lungs. So just a reminder on vector change. Another thing that we don't throw every cardiac arrest is sodium bicarbonate. Certainly consider it if there's concern for tricyclic antidepressant, for hyperkalemia, or a Benadryl overdose. But it's not necessarily something we throw in the kitchen sink. Again, that's based on research that says, okay, what happens if we give sodium bicarbonate to everyone versus selected patients? When we give it to selected patients, overall outcomes are better. Remember, if there's a delay in getting IV or IO access, you can't give epinephrine in the same sequence as the amiodarone. And then after the 5th shock, it's the time to contact medical control. But those are patients that is cardiologist dependent, but particularly with mechanical CPR, cardiologists will consider taking these patients with refractory VFib to the cath lab. And so those are definitely cases to consider. In terms of where this is going in the future, there are systems that are looking at eCPR, basically ECMO, for patients with refractory VFib. It needs to be a pretty salvageable patient that you can get to an ECMO center within a defined period of time, usually 20 minutes or less. So it's pretty limited in our county. The ECMO center is at Legacy Emmanuel. But within the protocol development committee, they're looking at, are there potential cases that can do that? It's not anything that's happening right now, but that's, you know, the future direction that EMS systems are looking at. How can we best help the patients with refractory VFib? Any questions about VFib, pulseless VTAC before we move on to PEA? The way I think of PEA is there's something, you know, the heart's telling you there's something there, but there's something that's blocking it. There's something, like there's a rhythm, but there's something that's blocking you from getting a pulse. And so this is where the H's and the T's become most critical. So with PEA, getting the epinephrine on early is the key to improving your outcome, and continuing that every 3 to 5 minutes. Again, you know, when you think about the airway management, really think about hypoxia in these patients, because that's, you know, unless we're sure we've corrected the hypoxia, we're not, you know, we can't be confident we've done everything we can to try to get these patients back. Acidosis, hydrogen ion, think about your oxygenation and then also your ventilation. Look at your pulse oximetry, look at your end-tidal CO2. Cardiac tamponade, that's a pretty rare case. When would you think about that? A patient that's got some kind of cancer in the chest. So a patient that has lung cancer, that has breast cancer, those are patients that they're prone to develop pericardial effusions. Patients on dialysis can develop pericardial effusions as well. Typically, those patients will be complaining of chest pain for some time. It's generally not like I had chest pain and then I collapsed, but like, oh, he's been having chest pain for a couple of days. But those are fairly rare cases. Hyperkalemia, most commonly we see that in patients with renal failure. Think about that in a patient that you know, hasn't been seen for some time, that hasn't been getting good PO intake. Hypothermia, so you get environmental clues to that, and you can use. Remember that a tympanic temperature for hypothermia probably won't tell you much. Probably better just to like feel the core of the patient and get some sense of if this patient is cold. With hypovolemia, think about the clinical history. Someone that was vomiting for days. It's someone that had some bleeding. Hypoxia, we've discussed. Pulmonary embolism. And the cases that have a really strong history for pulmonary embolism are going to be relatively rare. Anyone want to throw out what that history might look like? Pregnancy. Yeah, so pregnancy. And then what symptoms do patients that develop a PE often complain of before it becomes severe?
Difficulty breathing, chest pain.
Chest pain, and then difficulty breathing, chest pain. And the thing that really distinguishes PE from most of those other causes is that it typically had some kind of leg swarming before. And so the things that set people up for PE are the things that make your blood more likely to clot. So that's prolonged periods of inactivity, like long flights, long car trips, trauma, so a recent surgery, a recent car accident. Pregnancy makes, sets you up to be in a hypercoagulable state. And then there's typically like, there's some pain in the leg or there's something, something going on. And then all of a sudden, then they have this severe chest pain, they go down. That's like the saddle pulmonary embolism. We see plenty of patients that have small pulmonary emboli and you're fine, but the pulmonary embolism that's causing cardiac arrest typically is not subtle. There's, there's a swollen leg, there's a history of this sudden pleuritic chest pain. It gets worse by taking deep breaths. So those are the cases where you might consider transport, or at least discussing with medical control, like, could this be a pulmonary embolism? What treatment does the hospital have for that? In that case, you would be giving them thrombolytics. So, and we need to have a pretty strong story to suggest that that this is likely to be a PE. The pinch and pneumothorax, that's something that can come, pretty rare that someone develops it spontaneously. What would be the presentation of someone that develops a spontaneous pneumothorax? What would they complain of?
Acute shortness of breath.
Yeah. Acute shortness of breath, include one-sided. What are the patients that are more likely to have a spontaneous pneumothorax?
Really tall.
Yeah, tall, often thin, and more common in men. So those patients can have a spontaneous pneumothorax. Obviously, you can develop pneumothorax with CPR and with bagging. The signs it's gonna get harder to bag. You might see some decreased breath sounds on one side, but if you're thinking, oh, man, it's just got harder, can't do anything else, then decompression is certainly a consideration if you have a PEA patient. Then think about toxins. So what would the EKG look like if you have a tricyclic antidepressant or a Benadryl overdose?
Why?
Why? Yeah, and so in general, when you're thinking of a PEA, it's not always true, but in general, PEA with a wide complex is usually from some kind of a metabolic cause, whether it's hyperkalemia, overdose. There's usually some kind of metabolic cause if you have PEA and a wide complex. If you have PEA and a narrow complex organized, then that's usually some mechanical cause. So those are things like the pulmonary embolism, like a pinch pneumothorax. So narrow complex PA, think more likely to be a mechanical cause. Wide complex PA, think more likely to be some kind of metabolic cause. Questions about PEA? Then last we'll talk about management of asystole. So this is the heart that whenever it is stopped. Obviously, these are the patients that have the worst outcome. We do have survivors from asystole. Typically, if there's some bystander CPR, if it's witnessed, but these are the patients that are hardest to get back. So epinephrine early is the key in the treatment. In pediatric patients, again, it was because they became hypoxic. And so reversing the hypoxia is the most important thing. If it's unwitnessed and there are no obvious signs of death, then that is a case where it is reasonable to proceed with resuscitation. But if the patient is clearly cold, is beginning to develop rigor, then those are signs that the patient is asystolic and unlikely to be resuscitated. We think about other causes, but this is, whereas with PA, if you get those clues, maybe this is metabolic, maybe this is something structural. Definitely do think through the other causes, but the most important thing is to correct the ventilation status. In an asystolic patient, correct ventilation status, and then typically you will see them turn into PEA if that's what it is. And if you correct the ventilation status and you're not getting any response, these are patients that you're really unlikely to get back. Any questions about cardiac arrest management before we move on to arrhythmias with the pulse? Feel free, let's just say like 2 minutes, feel free to get up, stretch. I know so as a day is longer than I'd like to talk about. Like 2 minutes. Okay, I'm gonna go ahead and get started back. So now we'll take some time talking about specific arrhythmias. My emphasis here is on the thought process and how to puzzle through some of these. So with, first, we're gonna talk about wide complex tachycardia. So the key question with wide complex tachycardia is it stable or unstable? So what are some signs that a patient with wide complex tachycardia is unstable? Hypotension,
Mental status.
altered mental status. What does the skin typically look like?
Yeah. Diabetic.
Yeah.
Shots.
Yeah, so these are patients who look unwell. And so with if you've got atrial fibrillation with a wide complex, and those are the probably the trickiest ones where you have to think, are they sick because of something else? Or is the wide complex and rapid atrial fibrillation, or is the rate itself the problem? If the rate is less than 150, it's fairly rare that the rate itself is the problem. So we proceed with sedation and cardioversion. Can you cardiovert before sedation? Yes, it should be very, very rare. And I would encourage you to take the time, whether it's IM or IV, to give midazolam. I had patients who needed a cardioversion, refuse a cardioversion because they once got one without sedation. And then repeat it if it's refractory. If you don't get a conversion, then start with amiodarone, 150 milligrams. Give that over 10 minutes, and then you can repeat the cardioversion. If it's recurrent, you can repeat the amiodarone. If you're seeing some multifocal rhythm, think about torsades, think about magnesium. Once you get them converted, get a 12 lead to look for signs of ischemia that might be setting them up for that. For pediatric patients, again, pediatric patients rarely, unless these patients are peri-arrest, really, really important to give the sedation in advance. And again, you can use amiodarone if no conversion, 2.5 milligrams per kilogram, IV or IO, as a slow push, and then you can repeat again. At that point, I would start to be moving towards the hospital. Again, look for the 12 lead after conversion. Okay. And as a reminder, so in patients with a stable wide complex tachycardia, you can avoid the cardioversion and you can attempt amiodarone. In narrow complex tachycardias, the biggest question to ask yourself is it the rate that's the problem? It is when I've gotten fooled by seeing a narrow complex tachycardia, it was typically because I ignored some of the other things that were contributing. Are they tachycardic because they have a fever, because they're in pain, because they're in septic shock? What are some clues that it's the rate itself that's the problem? So, yeah, patients can have chest pain, and especially like chest pain, like I felt my heart go fast, and then I started having chest pain. That's a good clue that the rate itself is the problem.
The acute dizziness.
Yeah, dizziness, lightheadedness, especially with that acute onset and having it associated with the rate. If someone's in a sinus tachycardia, is their rate going to vary a little bit, or is it always going to stay the same? In a sinus tachycardia, if they're at rest, it'll stay in the same range, but it often will, you'll see on the monitor, like it goes to like 140, 150, 145. There's a little variation with a sinus tachycardia, just like, in a regular sinus rhythm, you see a little bit of sinus arrhythmia. When someone is in an abnormal rhythm, like an SVT, or an atrial flutter, the rate is typically fixed. Like it'll be, you know, most common one we see is atrial flutter with 2-to-1 conduction. And it's fixed at 150. And you look at the monitor and maybe it's 151, maybe it's 149, but it always stays like right at that rhythm. If you're unsure, you can give a little fluid bolus. And if you're seeing no change at all and the rate just stays fixed, that's a clue that there's something electrical going on that's making the heart incredibly regular. So in a stable patient, obtain a 12 lead in an intracomplex tachycardia. You can attempt vagal maneuvers. What's the most effective vagal maneuver?
The one
The
that works.
revert,
What's that?
is it revert where you lift their leg?
Yep, yeah, so where you lift the leg, so it's combining, so the modified vagal maneuver is where you have the patient blow, could be into syringe, can be just blowing out, and then you have them sitting, and then as they start to blow, then you lift the legs up. So rated conversion from an SVT with regular vagal maneuvers, like a sinus massage or bearing down by itself, is about 10 to 15%. With the modified vagal maneuver, it goes up to about 40%. So that's your first attempt. And then you can move on to the adenosine. And then if you have an acute onset of atrial fibrillation and the patient is tachycardic, they're not unstable, then those are the cases where we can use diltiazem. We do have good evidence came out in the last year that, you know, patients that we do treat for atrial fibrillation with rapid rate overall have lower mortality if they receive some treatment from the EMS. It helps to slow things down, helps to get things under control. In the emergency department, what are the key things that determine whether we cardiovert someone who's got a new atrial fibrillation? Onset. Yeah. And so, and that window has gotten even a little bit tighter. So obviously we worry about the possibility of stroke in someone who's been in atrial fibrillation because they can collect clots in the atria. Now it used to be up to 72 hours. Now kind of the outside recommendation is 48 hours and the more conservative recommendation is 12 to 24 hours. So if we get a patient in acute onset of atrial fibrillation and they can give us a good history. There's some patients who are like, yeah, I don't know, like I don't, you know, their heart's going 160 and I'm like, I don't feel like my heart's going really fast. Like I really can't tell from history if that patient has been in atrial fibrillation for a long time or not. But the patient's like, oh yeah, like at 10 p.m. all of a sudden my heart's sort of going fast and I'm starting to feel unwell. Then you have that good history. And those are the cases where the emergency department will move to have rhythm control, trying to cardiovert them. But it is safe to slow the rate down, make them more comfortable. Any questions about tachycardia before we move on to bradycardia? Okay. So bradycardia, similarly, the question is it the rate? Is it the bradycardia itself that's causing the problem? So what are some clues that it might be the bradycardia itself that's causing the patient to feel unwell?
Normal. They complain of
Lightheadedness, weak,
Yeah.
and especially when it's associated with the heart rate. Would you think it's more likely to be a rate problem if you see a 3rd-degree block or a sinus bradycardia? Yeah, 3rd-degree block, or even a 2nd-degree block or something. Like typically a higher grade block, something like that is like, okay, it's probably the rate that's the problem. Whereas it's a sinus bradycardia can make people symptomatic, but it's much more rare than in a sinus bradycardia. It's the rate itself, is the electrical problem that's causing the issue. So it can be from a number of causes. Obviously, the most common one we see is syncope with increased vagal tone. But in the moment when you're responding and you get someone who's got a pressure of 70/30 and a heart rate of 40, and it's a sinus bradycardia, you know, it's hard to probably it's vagal, but you don't know at that point. And so if it is sinus brady and if it is slowly increasing, then that suggests, okay, probably was vagal, probably is improving. Whereas if it stays or it's got some kind of abnormal bradycardia, that's a bigger clue that it's the rate itself that's the problem. Hypoxemia, well, you will typically see sinus bradycardia with a gradually decreasing rate. It's particularly like kids that get hypoxic and bring you down, but you'll see that in adults as well. Myocardial ischemia. So what region of the heart, if you infarct, are you more likely to see bradycardia? Interior.
Overconduction pathway.
You can say the interior if it goes around, and then where else do we worry about it? Like say if someone's got ST elevation and 2-3 AVL. Yeah. Left and then inferior, like inferior MIs will often break you down because they often the AV node is getting blood supply from that same pathway. So the ones where most about bradycardia are the inferior MIs. And so getting a 12 lead and then getting serial 12 leads can be key to figuring that out. So treatment, the 12 lead is really critical because anytime we're seeing this symptomatic bradycardia, we have to think about myocardial ischemia. If there's signs of poor perfusion, then proceed with atropine. If you have a 3rd-degree block, how likely is atropine to help? Unlikely. Not unreasonable to do as you're setting up for other things. But then the transcutaneous pacer for high-degree blocks is typically the critical thing that we need. Questions about bradycardia?
What about the semi-healthy late 40s, early 50s STEMIs that are the low 40s, mid 40s? It's the increased heart rate, increased oxygen demand, make the STEMI worse, or you just in the hospital, you guys just sit on that and wait, try to fix the heart first?
So there's a STEMI, like otherwise relatively healthy person with a STEMI.
And it's always bradycardic in the 40s.
Yeah, bradycardic. Yeah, typically in that case where the focus is just on delivering oxygen to the heart. So unless you're really seeing like hypotension that's impairing perfusion, we try to be as judicious as possible about trying to increase the heart rate in those cases, because exactly as you point out, you can increase myocardial oxygen demand if you increase the rate. That's one of the reasons that if you do need to intervene on those patients where you've got that ischemia, the pacer is a nice intervention because you can turn it off, you can dial it up, you can dial it down, and you can just give yourself enough rate to perfuse without overdrive. The atropine is going to last for at least half an hour. It's going to give you some effect. So if you really think I've got ischemia and they're hypoperfused, the pacer is an ideal intervention there. Does that answer your question? Okay. Any other questions about cardiac stuff before we move on to mechanical ventilation? Okay. So I think multiple people in the county are coming from different places with this. From their transport services that have been using ventilators for some time. There are first response services that haven't had much experience with ventilators. This project came out of a request from the hospitals for crews that are doing interfacility transfers to be able to provide ventilators to patients. But it's also our approach that, we from the medical director's office, we want to give you the tools. We want to let the people who do operations. And so with respect to mechanical ventilation, it is an option that transport crews have for 911 responses. We're not making it a requirement. But we want to get everyone on the same page. We want to give a common language and a common protocol for how to approach this. And so forgive me if I'm starting at a too basic level, but I want to kind of give everyone common framework to start to think about this and to start to understand this. So we can ventilate patients with the BBM or with the ventilator, just like we can do manual CPR and we can do mechanical CPR. We can do manual ventilation. We can do mechanical ventilation. I would think, for the medic that's using a transport ventilator, think of it as your partner who is going to do exactly what you tell them to do. And so they're going to deliver exactly the tidal volume that you tell them to do. They're going to deliver exactly the rate that you tell them to do. And so that has advantages, but it means you need to be really precise in what you're telling them. So just a reminder, for scene calls, it is an option. It is not a requirement. Okay, so let's compare. Well, if we look at the BVM versus a ventilator, what are the advantages? What are the disadvantages? So obviously BVM, pretty quick to set up. Ventilator takes a little bit more time. In terms of the tidal volume, BVM, biggest thing we see is you get variable tidal volumes. Even with someone who's being really careful in a really controlled setting, there's variation breath to breath. Ventilator, extremely reliable in terms of delivering that tidal volume. The IDE ratio, inspiration to expiration. So that's essentially how much, how much time does the in-breath take? How much time does the out-breath take? We know that any of us, as you're bagging, your rate varies. You can squeeze a little faster, you can squeeze a little slower. With the ventilator, that's extremely reliable. Respiratory rate is variable with manual bagging, reliable with the ventilator. With FiO2, typically with a BVM, we're getting 100%. As long as you're hooked up to oxygen, you're getting 100%. There's really not much variation you can do with that. With the ventilator, you can vary the FiO2. And so that's another tool that you have. PEEP is pretty similar with each of them. You can add PEEP to your ventilation. You can add PEEP to the ventilator. And so with BVM, it is anyone in a resuscitation, it is easy to hyperventilate patients with a BVM. And we do everything that we can to avoid that. That is something that's easy to do. The ventilator, it's your partner that does exactly what you tell, what they're told. And so if you have the settings too high, it will deliver higher pressure than you could deliver just with manual. And so there's the risk of barotrauma. The risk is low, but we do everything that we can to minimize that, because that's the worst case scenario with mechanical ventilation, is you can get barotrauma. That can be pneumothorax, it can be pneumomediastinum, it can just be over distension of the lungs. And so that is the outcome that we're trying to avoid with mechanical ventilation. We're trying to put up guardrails to avoid that. So what are the parameters that we set with ventilator? So you set the mode. Ventilators there are multiple modes. Most common mode is assist control, and you can either set it for a set volume or set pressure. In our setting, we're just going to be using a set volume. To use a set pressure introduces a whole bunch of other complications in the emergency department. I can't think of a time in my career that I've used a pressure control mode. That's something that might happen in the ICU. So the mode that we use is volume assist control. When we set a tidal volume, the tidal volume is based on the patient's height. And so if someone is 5'11", whether they are 130 pounds or 340 pounds, we're going to use the same tidal volume because the size of lungs corresponds most closely with the patient's height. The IDE ratio, we will set the IDE ratio, and we'll talk about the different strategies for how to set that. Then we set the respiratory rate. This is something that you're all very familiar with when you're giving instructions to someone on how to bag. And then we set the FiO2 in the PEEP. So this is those are the parameters that we use, and then this is how I think we kind of go through them in that order as we're setting up a ventilator. So the mode is going to be volume assist control. Then we think about, okay, how do we protect the alveoli? Talking about protecting against barotrauma. We do it by setting the right tidal volume. Then we do what we can to make the patient comfortable. Biggest influence on patient comfort, once you have the tidal volume set, is the I to E ratio. And so you can imagine, like, if you have a semi-conscious patient, you're delivering breaths that where it takes a really long time to exhale, like that could be less comfortable for the patient. Similarly, really long time inhale could be less comfortable for the patient. We'll give you guidelines on where to start, and then you can titrate that to patient comfort. Then we set the ventilation by setting the respiratory rate. Dial up, dial down, and we use our end-tidal CO2 to titrate that. And then the last thing that we set is we dial in the oxygenation by dialing in the FiO2 and the PEEP. Questions about that so far? Okay, so I mentioned tidal volume is based on height. And so this is the NIH table. You get the patient's height, you get their predicted body weight, and then you get the tidal volume in terms of milliliters per kilogram of predicted body weight. All based on the predicted body weight, and it's all just by going through the table.
Dr. Mock, is that the same as ideal body weight?
Yes, ideal body weight based on height. Yeah, those terms can be used interchangeably. Okay, so then what are the strategies? So for the vast majority of patients, we use a lung protective strategy. So the thing that we care about the most is preventing barotrauma. So we're going to do what we can to protect the lungs. The subset of patients that have different considerations are patients that have active obstructive disease, patients with active asthma, active COPD. In other words, you're hearing them wheeze, they've got a prolonged expiratory phase. Those patients, if you put them on mechanical ventilation, and the problem with obstructive disease is getting air out, and you don't allow them enough time to exhale, then you get breath stacking, and you basically just build up pressure inside the lungs. So for the obstructive strategy, the key thing is allowing the patient time to exhale. So here are the strategies in the protocol. We outline them step by step, and then we have this reference table for comparison. So for the lung protective strategy first, mode, volume, assist control for everybody. And then we start at 6 milliliters per kilogram of predicted body weight. This is based on the ARDS-NET protocol, which is the biggest study of how to ventilate patients who are at risk for developing ventilator-associated lung problems. And so you start at 6 milliliters per kilogram of predicted body weight, and then you adjust to get a plateau pressure less than 30. So if your plateau pressures are greater than 30, then you go down on the tidal volume. Less volume is going to give you less pressure. Goal there is just to protect the lungs. You'll start at an I to E ratio of 1 to 2. So if it takes take 2 seconds to breathe in, 4 seconds to breathe out. And then you can adjust that if you're seeing some discomfort from the patient. For the respiratory rate, typically you're going to start at whatever respiratory rate they were at prior to the intubation. So obviously, patients with DKA, patients with aspirin overdose, we try to avoid intubating at all costs. But if they were breathing 32 times a minute before you intubated them, then we need to set the respiratory rate at 32 times per minute after you intubate them to keep their acid base status. If a patient was apneic, start at 16 breaths per minute, but then you can titrate with your end-tidal CO2 to get them. Goal with the lung protective strategy is to get them into a normal range in terms of ventilation. With FiO2, just start at 100%. There's a table that'll allow you to titrate down after 5 minutes. But goal is after you intubate someone, you're just keeping them on a high FI2 as everything else gets settled. In terms of PEEP, we start with 8. We're trying to recruit the lungs. But then there's a table that walks you through and that correlates FiO2 and PEEP. And so you do that to achieve oxygenation and, at the safest ventilation strategy. And then the key safety check is just keeping an eye on the plateau pressure with the lung protective strategy. High plateau pressures, meaning the pressure at the highest point in the breath cycle is a sign that, okay, there's a lot of pressure on the lungs, and then I might need to turn down the tidal volume. This is, you go back to thinking of your partner who's bagging for you. This is like, it's getting harder to bag, like it's getting really tight, it's getting harder to bag. Okay, you're gonna bag a little bit less. Questions about the lung protective strategy? So we're going to move on to the obstructive strategy. Yeah, goal here is to allow a time to exhale. So as with everything, we start with volume assist control. We start at 8 milliliters per kilogram of predicted body weight. That's because we know we're going to have slower respiratory rates. So to keep up with the minute ventilation, we'll have slightly higher tidal volume. And we've started a low respiratory rate. With these patients, we can allow them to be hypercapnic. Right after intubation with someone who has obstructive disease, what you're really doing is you're relieving the work of breathing. You don't have to get them to normal capnia right away. It's going to take a little time and allow them to be that. The key thing is you're taking over the work of breathing and you're allowing them time to exhale. With FiO2 in obstructive disease, the problem is primarily that hypercapnia. It's usually less oxygenation than getting the carbon dioxide out. So you're going to think of a COPD, or you're going to titrate to a relatively low SpO2, so 88 to 92%. We want to limit that breath stacking, so we'll start with a PEEP of 0. If the FiO2 is at 100% and the saturation is still less than 88%, then you can add a little bit of PEEP up to 5. But primarily, the goal is to keep PEEP low in the patients with obstructive disease. And then, whereas in the lung protective strategy, we decrease tidal volume in a patient with that has obstructive disease, you're going to decrease the respiratory rate. Your goal is to allow them time to exhale. And that's what will decrease your pressure there. It just takes them longer to get that air up. And I think I skipped over the IDE ratio, but we start with a longer IDE ratio because the patients have a prolonged expiratory phase, so we're meeting them where they are.
What's the biggest risks of changing the rate on the obstructive strategy? We typically see a number at high entitled CO2. I would say a general idea is to decrease it. We know not to do it over time. Mm-hmm. You have to wean them down to a lower capnography number. But what is the risk? What's the outcomes that you'll see if we do that? Maybe not on purpose, too fast.
Like if you take the respiratory rate down too fast?
No, we increase it to blow up.
Yeah, if you increase it too fast, the worry that you get into breath stacking, and so you're going to see that with an increase in plateau pressure. In the obstructive strategy, if like this is not working, the pressure is high, you can always just like take them off the ventilator for a second and I've even like just given some gentle pressure on the lungs and just allow that release. And you can, if you need to, you can bag them temporarily. But yeah, it's just that breath stacking and just building up too much volume in the lungs.
Is there a metabolic change that you need to be worried about as well, or does that not necessarily matter?
You can, patients with obstructive disease tend to they buffer. They develop a respiratory acidosis, and so then they compensate with a metabolic alkalosis, and they buffer over time. And so the key thing, in the minutes after you intubate these patients is just to make sure that you're allowing them time to exhale, and then you can start to titrate them, but it's okay to leave them hypercapnic. That's we can use blood gases to titrate what we're doing with that, and the change. When you intubate someone who's really hypercapnic, I mean I'll take an hour. Like I won't check the gas for like an hour at least from the time that I intubate them until an hour later. I'll be like, okay, am I moving in the right direction? That's something. If there's someone who's severely hypercapnic, I mean, it's gonna take them like 6 to 8 hours to bring them back down to a normal-ish entitled CO2. It's a process that takes a lot of time.
But what about the lung protective strategy? Is that more like 10-minute change? You can adjust that. You start with your initial respiratory rate that they had, but it's less of a problem if you change it quickly.
Yeah, it's less of a problem if you change it quickly. These patients, you're not worried about breath stacking. You're basically trying to get to a more normal physiology. So the two clinical situations where you're going to be doing this, either you're intubating someone for a non-pulmonary problem, they have a head injury, they have overdose, they lost the ability to protect their airway, and so you just want to ventilate them safely, and you don't really need to accomplish anything with the lungs. The other clinical situation is you're doing this with someone who's hypoxic. So that can be a patient with CHF, that you couldn't turn around with non-invasive ventilation, or it could be a patient that has pneumonia. And so the key thing that you're doing with the ventilator is you're oxygenating them, and that's where the FiO2 and the PEEP are really your key interventions. But those, patients with pneumonia, with COPD, it's an oxygenation problem more than a ventilation problem. And so the lung protective strategy allows you to protect the lungs while you're oxygenating them, because it isn't primarily a ventilation problem, you get fairly normal with the ventilation. And they typically, unless you've got a lot of a mixed component, you typically will see them normalize pretty quickly in terms of their ventilatory strategy and in terms of what the entitled CO2 looks like. Other questions about this? So I know this is a lot to think about. The key thing, number one, it's an option, it's not a requirement. Number two, but it is a tool that you have in your toolbox to whether it's practical, either because of a long transport, because of the kind of resources you have on scene. It's a tool that you have in your toolbox. Obviously, it's something that has been happening for some time in some services. Having everyone on the same protocol allows us to do quality improvement, allows us to look at how this is working. I imagine that we'll refine this over time, but this is based on a paper by Scott Weinkart about initial mechanical ventilation in the emergency department. It's supported by the National Association of EMS Physicians position paper on mechanical ventilation. It's just kind of a down the middle, straightforward approach to the mechanical ventilation in EMS. But that said, we want to hear feedback. I want to hear how it's working in the field. Other questions? Or anything else online?
Nope, nothing online. I'll remember to fix the typo in the protocol.
Thank you.
Yeah.
So key take-home points. Good BLS is the foundation for all cardiac arrest care. ALS management of cardiac arrest is about specific therapies for specific problems. I encourage you to share your mental model and refine that over time. That's how we get everyone on the same page with respect to resuscitation. In terms of treatment of arrhythmias, think about is the rate is that underlying rate the primary problem, or is there something else that's causing the patient to have a fast rate? And then in terms of mechanical ventilation, just think of it as tool that you have. It's your partner who will do exactly what you say. So you have to be really careful what you tell your partner to do. With that, I'll wrap up. Please, you can scan that QR code to give feedback. We'll put the link into the chat as well. Thank you very much. Really appreciate your time and attention.